Before we will get started, good evening all to the Weekly Huddle. My name is Anup Agrawal. I'm an interventional cardiologist at Care Hospital, Hyderabad. I'm joined by my colleague and co-host for the huddle, Dr. Praneeth Pelamuri, and we both welcome all of you for joining us. The huddle concept is being an unscripted audience level interaction where we address common clinical scenarios, case studies, and recent research as it comes along. We discuss about particular patients, how we manage, something that we would discuss in our daily hallway. We typically pick up a topic and or a clinical case, and we try to restrict our discussion around that. The basic premise of the huddle is to bring our casual hallway discussions into a more organized platform like this one and share our ideas. I have been told my volume is a bit low. Let me see if I can make it better. While science and guidelines are welcome in this discussion, with Huddle, we tend to help a physician translate what is established knowledge to clinical practice, taking local factors and practice patterns into account. We host this session every Wednesday at 7:30 p.m. This is our 38th session. And for today's session, rather than choosing a topic, we have chosen a clinical case, which is a very routine, very low profile, regular clinical case that we will see in our daily practice. And the idea here is, rather than restricting to a particular entity, if we can discuss how we manage these kind of patients, things which are so common for us, which are so reflexive for us that sometimes we don't give too much thought on it. And in today's discussion, I'm trying to bring up whether we should be giving more thought to this as well. I have shared the clinical case summary in the chat box so people can read through it. I am going to speak out the clinical case. I will ask my colleague Praneeth to give his initial impression, and then we will discuss amongst the attendees. So Praneeth, this is a 58-year-old female. I saw her a few months ago. I'm going to present it as if you are seeing her for the first time. She had got a bypass surgery around 5 years ago. She's 58 now. Bypass surgery was around 5 years ago. At that time, she had anterior wall MI. Her ejection fraction after bypass surgery was 40%, and that is what she had been on since that time. She does not have diabetes. She does have diagnosed hypertension, but no other medical illness as such. She comes to you for the first time to see you as a routine follow-up. She has not seen any cardiologist for more than a year now. She does not report any active symptoms, and she mostly is active doing her household work. She's not more active than that. She has got one floor at her home, which she's able to climb without any major difficulty. She does not have any heart failure symptoms, and she never needed to do any more physical activity in the last few months. Her blood pressure in the office is 130/86 with a heart rate of 82. She does not check her blood pressure at home. Her physical examination that you did and the basic lab work, which includes hemogram and renal profile, had been within normal limits. Her ECG suggests poor R wave up to V4, precordial leads, otherwise no any active ischemia. Her QRS interval and PR intervals had been normal. You did an echocardiogram on her because it has been more than a year now, and that showed an unchanged ejection fraction of 40%, and her anterior wall is hypokinetic. She is on a chronic medication which includes Ecosprin Gold, which is a brand. It's essentially a combination of atorvastatin 20 milligrams, Ecosprin 75 milligrams, and clopidogrel 75 milligrams. She takes that tablet at night. And she takes Metexcel 50 milligrams, which is metoprolol succinate, in the morning. Those are the two tablets that she is on. And she once a while takes multivitamin whenever she feels a little bit dull. So this is the overall situation, a very common patient that any cardiologist would see. She's otherwise okay, no real problem. And the questions that are going to be for us, and this is in this particular order, if you could address those questions. Would you continue the same treatment that she's on? She's doing fine, she's not complaining of any problem, or would you modify this treatment? Would you stress her? It's been about 5 years, she had got surgery. And if you would stress her, what test would you use? Any other ancillary cardiac evaluation would you take other than your regular ECG, echocardiogram, and the basic labs? Any role of lipid targets? Now, this patient did not have a lipid profile done. Would you worry about it? Would you do anything for lipid targets? So just walk us through. This is a very routine patient, nothing fancy. It is a horse. It looks like a horse. It sounds like a horse. It is not zebra. It is not something very fancy that we are talking about. Walk us through your thought process, and then I will invite my attendees to share their thoughts as well. Praneeth, take it from here.
Thanks, Anam. Good evening, everyone. So, I would look at this patient as having coronary artery disease, ischemic cardiomyopathy with moderate LV dysfunction. So, revascularized, right now asymptomatic. I will discuss about heart failure in this patient. So, for me, she belongs to heart failure with reduced ejection fraction. NYHA class 1 to stage 3. So I would try to prevent her progression or stabilization of heart failure. These are the common pool of heart failures which are usually missed. So I would be aggressive in managing her heart failure. So when I say aggressively managing, when her ejection fraction is less than 40%, in addition to 2 or 3, she taking a beta blocker, the 4 so-called pillars of heart failure therapy which are currently advocated, I would try to give the 4. Meaning one, the RAS inhibition, particularly with an ARNI, the beta blocker she is already on. The third one would be the mineralocorticoid receptor antagonist, that is either a spironolactone or eplerenone, and also the current literature on SGLT2 inhibitors, either a dapagliflozin or an empagliflozin. So these are the 4 drugs which I would try to look into to include in her prescription list. The second thing is about her whether stress test to be done. She is able to do her day-to-day activities. Right now, I am not in any intention to do any stress test because probably it doesn't change any line of management to me because she is asymptomatic. The third drug about any other specific investigations that you looked into it, and also about lipids. Yes, because she already has an ASCVD event, I would target her lipid levels to be very low, preferably less than 50 of LDL. So I would recheck her lipid profile, try to particularly focus on LDL cholesterol. Also pay attention to other parameters, but my focus would be on LDL, particularly with a target LDL of less than 50. She is on the gold, which contains a low intensity statin, that is atorvastatin 20 milligrams. So I would be trying to or inclined to step up her statin to at least moderate intensity, and probably if the effects are not there, maybe go to high intensity statin as well, and keep her under regular follow-up and titrate these parameters with a heart rates targets of close to 60 to 70 and blood pressure targets of less than 130/80, and uptitrating the maximum tolerated doses of the so-called heart failure therapies. So that would be my take on this patient.
Praneeth, 2 questions I have for you. Number 1 is, this is a 58-year-old female. She had bypass done 5 years ago. What does that tell you? And second, dual antiplatelet therapy. She is bypass surgery after 5 years. If you could just throw some light on that.
Yeah, so your point is valid. So for someone female less than 55 years of age has an ASCVD event, that is a red flag. So that begs to the question of evaluation of any family history of an ASCVD, or screening the family members for ASCVD risk, and do their screening to prevent an ASCVD event in the first degree relatives of this patient. That is one thing. And regarding the DAPT therapy post bypass, because she's a young patient, and my take would be that unless patient has any contraindications on taking DAPT therapy like bleeding or any other side effects, I would continue DAPT therapy for them unless it's contraindicated.
Thank you, Praneeth. I will invite my attendees for the discussion, and this is for everyone. I have shared the case summary in the chat box, so if anybody wants to review that, they are welcome to do. And if anyone has any thoughts to share, you don't have to wait for your turn. You can unmute yourself and speak, or you can raise your hand and I will call your name. So if anybody has any thoughts, please feel free to share with us. I'm going to invite Dr. Chandramukhi. She's a senior cardiologist at Care Banjara. Dr. Chandramukhi, I hope you got the case summary with you. My question to you are the same 4 questions that I'm asking everyone, which is continue the same treatment versus modify. She's feeling absolutely fine. Role of stress test, and if yes, which one? Any other ancillary cardiac evaluation, and role for lipid targets. Chandramukhi ma'am.
Thank you, Anu. Good evening, all. This is a lady post CABG 7 years ago. She's asymptomatic. So, regarding the DAPT, I would like to give her a single antiplatelet, either ecosprin or clopidogrel. Regarding the statin therapy, achieving the LDL level goal of 70 mg would be my goal, and according to the lipid profile, I will modify the dose of statins. Stress test, even though she's asymptomatic, I would definitely like to evaluate her in the form of stress test, because, and one more thing, I would like to check her echo again, because you told that LAD territory is hypokinetic, it is not akinetic. So I would like to really assess her LV ejection fraction and what is the LV dysfunction. And regarding stress test, I would like to do the stress echo in the form of dobutamine stress echo, because already her ECG is abnormal with poor R wave progression, and DSE will give us fairly good idea about the stress-induced ischemia. This would be my take for this patient.
Thank you so much, ma'am. And I'll take 2 minutes to highlight my rationale of bringing this particular case other than the routine discussion. I have been told by pharmaceutical representatives that ecosprin gold is the most common prescribed triple therapy drug in Indian market. And to me, that sounded a very big oxymoron, a very big contradiction. And here is the reason why I say so. Ecosprin Gold or any such medication, I'm not just putting on Ecosprin Gold. The reason why I'm putting this particular brand, because I have been told this is the most frequently prescribed medication. Ecosprin Gold has an intermediate dose statin, which is atorvastatin of 20 milligrams, and it has dual antiplatelet. Now, I put dual antiplatelet on those patients who are at high risk for recurrent ASCVD event or recurrent MI or cerebrovascular event or whatnot. And those patients who should be getting a dual antiplatelet, which means by definition they are at high risk, they should be getting a high dose statin irrespective of what their cholesterol level is. So combining intermediate dose statin with 2 antiplatelet, essentially we are contradicting, where we are putting one therapy regimen which is given for high risk individual and second therapy regimen which is not given to high risk individual. So in a sense, this particular combination does not do justice to the patients. That is my thought process onto it. I personally would not give 2 antiplatelet therapy in a person and not give them a high dose statin unless they are not able to tolerate or they have got any side effects or any adverse effects because of that statin. So that was one aspect of why I wanted to discuss this. I also want to highlight 2 things as we go along the discussion. One is ESC and ACC both, or first ESC and then ACC, revised their lipid target level in 2019 and 2020 respectively, where for a patient who had a previous event, the LDL targets have been more aggressive, going from 70 to 55. How much of us are practicing that? That is another aspect. This is certainly being more aggressive, which means we have to be looking into it far more generously than what we have been doing so far. And second, and then the other one is the role of stress test in asymptomatic patient. Now the guidelines do permit us to do one stress test 2 years after stent and 5 years after bypass surgery, and that science is also not very clear. Lot of it is individual doctor's decision, individual patient tailored decision and whatnot. So that is again something which I think is worth discussing, particularly for bypass patient who finished their 5 years of asymptomatic period, whether it adds any value or not, and if it does deserve a stress test, how do we go about it? So these were the things which were going at the back of my mind when I put up this case. One thing that Praneeth very adequately mentioned is the role of escalating heart failure therapy, even in patients who are totally asymptomatic. Means in this patient, probably it's class 2 because she is not working hard. If she had to exert too much, maybe she will get symptomatic. So those are the thought process on which we are working around. And with this, I'm going to look for other people whom I can ask for their thought process. If any one of you has any thought, please mark yourself. Dr. Santosh is here with us. He is a young appointee at Care Banjara. Dr. Santosh, I hope you got the case summary and you got the questions that I have been asking. What is your thought on this patient? How would you take up this case? Dr. Santosh, please unmute yourself.
Sir, first of all, from DAPT, I will make it as a single antiplatelet. And adding all those drugs which has proven the mortality benefit, one MRA, second SGLT2 inhibitors, that I will add to this patient along with other AC inhibitors or ARNIs, sir. And regarding the statins, if the statin target is less than 55 on 20 mg atorvastatin, then we'll continue the same, or else we'll escalate the statins according to the LDL, sir.
Perfect. Thank you so much. Thank you so much, Santosh. I'm just going to go down the list and see. I have Dr. Bharat here. Dr. Bharat, if you could please unmute yourself, give me one line introduction, who you are, and if you could throw some insight of how you would manage this case.
Thanks, Anup, but sorry, I joined just now when you were telling about the ESC guideline and how we have reduced the targets from 70 to 55. So I was just going through the summary which was there in the WhatsApp regarding a 58-year-old female who had a EF of 40%, and then she's on EAPT with atorvastatin and metoprolol. To be very honest, I'm not fully aware about the case scenario. What was the graft put, whether they were all arterial graft or they were one lima and other vein grafts. So can you just, I'm sorry, I joined late. Can you just tell me?
So, sir, the case scenario is such that this patient is coming to us for the first time. We don't have any previous details. All we know is she had got a bypass surgery around 5-6 years ago. And she had not seen any doctor for the past 1 year. The last time she saw was pre-lockdown. She had been doing okay. It is just that she never visited any doctor. And now after all this lockdown and whatnot, she is coming to re-establish care with some cardiologists. So we don't have much information except her previous doctor's notes, which says that her ejection fraction was 40%, and that is what it is now. And then the questions
you have very elegantly said that we need to reassess the lipid level in this patient, and one thing is very clear: there is no role for dual antiplatelet at this point of time when the patient is 5-7 years post acute coronary syndrome or a CABG or a PCA, whatever they have done at that point of time. So she is a stable CAD, so-called stable CAD at present. And because his ejection fraction is 40%, we don't see any other drug other than a little bit of metoprolol. So based on the blood pressure, we definitely need to escalate the beta blocker and add, as one person was saying about ARNI or ACE inhibitor or ARB based on patient preference. If the patient is financially stable, then definitely ARNI. Otherwise, patient can still be managed with a conventional ACE inhibitor or ARB, because still the patient is not grossly symptomatic. And statin level definitely based on lipid level, we can take a call whether the patient statin level, what is the dose we need to give. Dual antiplatelet definitely is not needed. Regarding whether the patient has developed a reblockage or not, whether to do a stress test or not, if the patient is asymptomatic, I will personally not be very aggressive in terms of assessing a stress test or do a CT angiography to check for the patency of graft and all this thing, because there is a post CABG patient, and I have never come across any recommendation which says that you have to routinely do a stress test in these patients who is absolutely asymptomatic to decide whether the grafts are still patent or not. So just hike up the medication, optimize the medical therapy which the patient is taking in terms of their statin dose, in terms of single antiplatelet, hike up the beta blocker to the tolerable dose, add one ACE inhibitor or an ARB, and that's all. Diuretic at this point of time I will not give because he is absolutely asymptomatic, but he doesn't require any volume reduction. So I think that much. That's what I will prefer to do in this patient.
Sir, one particular question to you, and this I have been asking to the attendees. This is a 58-year-old female who got bypass surgery at the age of 52, 53. No risk factors. Does that trigger for you to do something about this patient, or you think in an Indian setup there isn't any point digging because most of the time our genetics makes us predisposed?
Digging in the sense, you are asking that whether we should be checking whether the grafts are patent or any new blockage have come. Is that
I'm particularly talking about her being the family history for her offsprings, for her
you want to
siblings.
check whether the other relatives we should be evaluating or not, right?
And also if she has got any underlying reason why she got atherosclerotic disease at the age of 52, which typically females don't get.
Yeah,
or you think it is too common?
When we do it, see, I think the general checkup, see, like risk factor profile in terms of blood sugar and lipid profile, all this thing anyway will be done as a part and parcel of routine evaluation. But to do some novel markers to check, I do not know how much those novel markers truly help us in managing the patient. From academic point of view, yes, we can definitely do a lipoprotein little a or apolipoprotein and all those novel markers, we can do it. But truly, what is their significance in terms of therapeutic benefit is still a debatable issue. Definitely, the relatives has to be reassessed because she is a young lady. As per our guidelines recommendation, anybody less than 65, she has a CAD. Definitely, it puts the relatives into an added risk factor. So when we talk about the relatives like his son or younger brother, if anybody is there, then we need to, when we assess their ASCVD risk factor, then this definitely family history of CAD definitely puts one extra point in that, and then accordingly we can assess their risk profile and take a call how best we can manage their risk factor in those set of patients.
Perfect. Thank you so much, sir. I'm going to go down the list. I have Dr. Shankar here. Dr. Shankar is a senior physician. Sir, give us your insight. I'm sure that you are also seeing patients like these in your OPD, and you probably have been seeing for past couple of decades or so. Stable patient, 5-6 years old, bypass surgery on minimal medications. Should we tinker around too much or should we leave it at that? Dr. Shankar, if you could throw some insights on it. Dr. Shankar, you'll have to unmute yourself before speaking.
Good evening to all.
Yes, sir.
You have raised 4 issues in this case regarding the LV ejection fraction less than 40% comes under HEPREF. So here the patient is only taking only beta blocker. So I would like to add AC inhibitors or ARBs if the patient is affordable, and definitely I advise even ARNI also in this case. And regarding the diuretics, patient cannot tolerate the loop diuretics. In this case, I would like to add the thiazide or thiazide-like diuretics also, along with the AC inhibitors, conventional ramipril, 2.5 mg plus 12.5 mg of CTD or ACG. Then regarding the treadmill test and dobutamine echo, probably the patient may not be cooperative, and because of her limited physical fitness and a false positive interpretation of stress ECG, and patient may not be cooperative, and patient may, because here the LV ejection fraction is less than 40%, the dobutamine echo may pose some problem. I would like to go for the stress thallium to see any ischemic defects in the myocardium. And regarding the lipid target, the patient comes under high risk group. See, here the very high risk group, I say, because according to the ESC guidelines, documented ASCVD, either clinical or image, or prior MI with PCI or CABG. So here prior MI with the CABG, she comes under a very high risk group. So I would like to have this LDL-C cholesterol target level less than 55. If 20 milligrams of, to get this 55 milligram per deciliter, we have to exhibit high intensity statin. I would like to increase the atorvastatin 20 to 40 milligrams atorvastatin I add. Regarding the antiplatelet agents, as far as my knowledge goes, we go by DAPT score. After 12 months of uneventful DAPT, taking into criteria the age, smoking, diabetes, myocardial infarction at the presentation, prior PCR, prior MI, and stent diameter. So all these things, there is a score, www.daptstudy.org. If you go through, then there are the -2 to 10 score points are there. If this patient has got a score more than 2, I prefer rather than standard DAPT for DAPT for 12 months, I give prolonged dual antiplatelet drugs in this case.
Perfect. Thank you so much, sir. Thank you so much, sir. I think you highlighted a lot of good points. One of them is tailoring therapy based on individual patient risk profile, and DAPT score certainly look into one of these. DAPT score was originally researched for, or it was put up for the original DAPT trial, which was a prolonged dual antiplatelet after 1 year of stenting. And I remember Dr. Molly was the PI for that, and there was a lot of discussion about how much value it adds, but certainly it did prove that it reduces the overall MACE event in high-risk subsets. Absolutely point well taken, sir. Let me invite other people for their thoughts. I am trying to see who else is there. In the meantime, if anybody has got any other thoughts, they can feel free to share. Dr. Kapil, if you can hear me, could you please unmute yourself, introduce yourself in one line, and give us your thoughts about this particular case? Dr. Kapil.
Yeah, hi, Dr. Anup. Hi, everyone. Yeah, it's like patient here is a 52-year-old female with post-CABG, 7 years, stable patient with no risk factors. Yeah, when you ask that question, whether to investigate for the reason for a CABG at the age of 52, then yes, I think we should do that. But in Indian context, it is not being followed. But Yeah, that's a good thought. We should do that actually. Next is, as other people discussed regarding mortality benefit and the drugs which have mortality benefit like MRA and AC inhibitors and beta blockers escalating their dose and titrating to the symptoms would be a better option. And she's like, now I think she's 58, right? So she might come back for some cataract surgery or some other surgery. Then we should take that opportunity to investigate her for possible ischemia, because one or two grafts would be definitely SVGs. So there would be some progression, though she is asymptomatic, and our stress test was never done in last 7 years. So we should actually take that as an opportunity to risk assess her, and probably if there is anything which we can, if we can help her in that particular thing, I think we can prolong her life as well, and we can give her a better life. And I think exercise post post CABG or post PTCA, there is something called cardiac rehabilitation that is not being followed, at least in Andhra Pradesh and Telangana. I have a friend in CMC who has done his physical medicine, and he's stimulating the post CABG and post PTCA patients to run marathons. So, as you said, she has a limited physical, she has limited her physical activities. So that's why probably she's not symptomatic at this point of time. But if we have a chance to do some stress tests, probably we would definitely probably demonstrate some ischemia, and she might be subjected for a procedure if she is going to be benefited with that.
Thank you so much, Dr. Kapil. I think it was quite relevant to also think of what future needs she may have and act accordingly. Dr. Kapil, if you don't mind, if you could just share, you are in Hyderabad or outside, and which hospital you work at?
Yeah, I'm in Hyderabad. I work with Apollo, placed at Hyderguda branch.
Perfect. Thank you so much, Dr. Kapil, for that wonderful insight. Let me go through the list and ask other people's opinion. Dr. Venkateshwarlu, sir, if you can hear me, could you please unmute yourself and share your thoughts about this particular case? Dr. Venkateshwarlu, I hope I'm pronouncing your name correctly. Sir, if you can hear me, please unmute yourself and share your thoughts. Okay, while we get to him, I'm going to move forward. Let's see who all is here. Dr. Srinivas Raju is with us. Dr. Srinivas is a cardiologist with Care Group of Hospital. Sir, I did put in the case summary in the chat box. I hope you got a chance to read through it. And we have been discussing various ways by which we can make her medical therapy a little bit better. Please ask me if anything in her clinical history that you didn't get, and share your thoughts about this particular case. Dr. Srinivas?
Yeah, sorry, Dr. I just joined in a bit late today.
Sir, did you get the case summary, or you want me to repeat it for you?
Actually, I don't have the details of the case. Can you just quickly tell me what it is?
Yes, so, sir, this is a 58-year-old female who got a bypass surgery about 5-6 years ago. We don't know the details of it. Her ejection fraction is 40%, which is stable. She's currently asymptomatic. Seeing you after a year, she does not report any symptoms. She's non-diabetic, no other risk factors. She takes Ecosprin Gold and Metexel. Blood pressure is 130. And she came to you for any further advice what we should do. So we are talking about whether we should modify her regimen, treatment regimen, which currently is Ecosprin Gold and Metoprolol. Should we look for why she got atherosclerotic disease at age 52? Should we do some other investigation? Should we do a stress test on her? and should we be targeting her lipid goals? So these are some of the management points that we are talking about.
Sure. That Anup, why is that her LV function is 40? Like, was it an infarcted? Was
Yes.
it in any particular territory that she had an infarct?
Yeah, so when she originally presented, she presented with an evolved anterior wall MI, and her ejection fraction post-bypass surgery was 40% with anterior wall hypo, and that is what she is currently on as documented.
Sure. So I presume there's no new RWMA which was noted on echo in any of the other areas.
Yes.
Okay.
Yes.
In that, if she is asymptomatic, if there's no new RWMA and she is not asymptomatic because for any reasons being restricted, then if she doesn't have diastolic dysfunction, if there's no new MR which you have seen, if there's no new RWMA, if she is not going for any surgery, provided her baseline ECG does not show any LVH or an LVBP, if she doesn't have joint pains or back pain, still we can do a TMT. But if she expresses that she has back pain or joint pains or a ECG is such that we can't do a treadmill test, then DSC if she is going for a surgery. But otherwise, there's no need for any further investigations if she is not going for any procedure as of now. And if we don't have the graph details too, I mean, if she's going for a surgery, CT angio is also a good option to know where the graphs, what graphs and all, how they are functioning.
Perfect. Thank you so much, sir. There certainly is a role for CT angiogram post-bypass surgery. In fact, post-bypass surgery is one of the classic patient subset where CT angiogram gives a very good information. Not only you know where are the grafts, but you also know the patency and whatnot. Whether in an asymptomatic patient, whether we should be doing or not. As Dr. Srinivas said, that sometimes in preoperative you may have to do it. We'll continue our discussion with other attendees. Let me invite somebody else. I'm just looking for who all is here. In the meantime, if anyone has got any other thoughts to share, please unmute yourself. Dr. Saket, I think he is not online anymore. Dr. Mallikarjun, he is not online anymore. So while you gather your thoughts, I'm asking all the attendees what they would do. I will share what I would do. So if this patient would come to me, I typically do not continue dual antiplatelet for post-bypass surgery beyond a year. So I typically take that medication off. I do keep a very strict lipid goal with an LDL-C of less than 55. And I do keep them on high dose statins regardless of what their cholesterol level is. So if this patient has a cholesterol level of 50, on 20 milligrams of atorvastatin, I still give it 40 or 80 milligrams of atorvastatin or 20 milligrams of rosuvastatin. I typically do not prescribe a combination of intermediate dose statin and dual antiplatelet. In my opinion, that is an oxymoron combination that should not exist. I will dig a little bit deep in terms of why this patient had to undergo bypass surgery at the age of 52 in terms of atherosclerosis versus non-atherosclerotic disease. I remember one time in a young patient, I told them to go for CT surgery, CT angio, just to look at the background disease, because sometimes patients, they do get surgery for non-atherosclerotic disease like a dissection, like a burnt out Takayasu or whatnot. And that gives us some idea about the background pathology, why this particular patient underwent surgery. I do stress them once 5 years after bypass surgery as a routine stress test, and my stress test of choice is thallium or a technetium system EB scan. Particularly in patients with regional wall dysfunction, I do not subject them to a stress echo, because if you have a background wall motion abnormality, then stress echo becomes a little bit difficult to interpret. I do not subject them to TMT for any patient who did have a previous event, because TMT has a very low diagnostic yield in a patient who already had an event. So there I do combine with imaging, either in an echo or a myocardial perfusion. I don't choose echo. If there is a background regional wall dysfunction there, I directly go for a technician scan. And if I were seeing any of her family member, then for that particular family member, she would constitute a positive family history. So I would suggest that family member to aggressively go for risk factor reduction and early detection of coronary artery disease. And the same thing I would do to her, where I would tell her first degree relatives to aggressively look for risk factors and aggressively treat those. So either in the form of high sensitivity markers, cholesterol, calcium scoring and whatnot, but I will certainly advise her family members to undergo a reasonable screening to look for early markers of atherosclerotic heart disease. So that is what I would do on this patient. As far as heart failure is concerned, that I think is very well covered in here. This patient, even if she is stable, she deserves escalation of heart failure therapy, either in the form of ACE, ARB or ARNI. In the current generation, we would put her on ARNI along with that spironolactone in the next visit if her potassium stays okay, and later on SGLT2 inhibitors if her sugars are slightly on the higher side. I understand that SGLT2 is recommended and approved in heart failure patients who are non-diabetic. That is one practice I have not started following yet, although this is something that I look forward to. I typically give SGLT2 in those patients who either are established diabetic or their sugars are slightly on the higher side. I still have not started on all comer, and that is also something that we can discuss in this meeting. If nobody has any active comments right now, I would like to invite Dr. Somaraju for his comments. Sir, you have heard all of us sharing our thoughts for this particular patient. Please tell us how you see this patient and how you would address these particular scenarios. Dr. Somaraju.
Thank you, Anup, and I agree with everything you said. I won't be repeating and re-answering some of those things and certain of the drugs and certain other issues. Before I talk anything more, you said you have to imagine and you have to convert it into a life situation in the way you practice and your practices. What happens in your practices and what happens to your patients, and guidelines and all those things are they are helpful, but individualization of patient is fundamental. Suppose I say that there is a patient who is operated at 52 years of age, a lady who is had an anti-MI and had a bypass surgery after anti-MI, and then there is no ACE inhibitor given to this patient, and then I would want to know what was the name of the say hospital where she was operated, who was the cardiologist, who was the cardiac surgeon, because in real world, as we know, they go hand in hand. Somebody who does an operation for somebody with anti-wall MI, either a surgeon or cardiologist, who doesn't give ACE inhibitor ARB in such a patient, I still doubt. I may have doubts about even indication for surgery in this patient. Considering that type of issues, and I'll want to know more details, and not to follow up this patient is another indication as to what type of people operated on this patient, what type of people decided on the need for surgery after anti-wall MI, and if the previous angiogram is available, I want to see, I want to know the operation details, and then coming to something somebody said, the heart failure. There's no evidence of heart failure in this patient, and then I'll straight away go for a lot of other things I wanted to say, but two things I'll point out. One is the drugs you mentioned, Ecospin Gold. This combination of medicines of more than one drug, when they are given, dual antiplatelet therapy, some of you said right and it's wrong. And then this combination of drugs, their bioavailability is never clearly available. One should not fall for such things in the long term. And I'll also add that this patient straight away needs a CT angiogram because that is the best way of assessing the grafts. The type of, say, no risk factor and then surgery done, no follow-up. I would doubt even the indication for surgery, what type of grafts are given and how they are patent, I would like to know. Entry wall MI, after entry wall MI, somebody decides on surgery, it has to be a special, particular anatomy that is suitable, particular viability that is suitable. I have serious doubts about everything that this patient went through. Thank you.
Thank you so much, sir. Just to play the devil's advocate, because we don't have her previous history, I don't want to assume that post-surgery or at the time of surgery, she was not on all these medications. Possible that she was put on appropriate medications at that time, including ACE inhibitors or ARB or whatnot, and maybe over the period of time, those medications had been dropped, where now she is on this basic 2-tablet therapy. I'm assuming that. I don't know those details. The only detail I know is more than 1 year ago, outpatient, a simple sheet written by a doctor where these two medications were written. So I have to give the benefit of doubt to the original place where she got surgery. It is very much possible she was on ACE inhibitor therapy for a year or two, which later on got dropped. I don't have that information, but I do want to give the benefit of doubt at that time. I do want to emphasize that this is what I do, and it doesn't have to be the only way. That whenever these kind of situations are there where this atherosclerotic disease does not fit into the game, I do order CT angiogram at times just to understand the background pathology. Sometimes you identify Takayasu, sometimes you identify some other disease which may not necessarily be atherosclerosis. And what Dr. Somaraju said, with all skepticism, sometimes you question the indication of bypass surgery itself with the disease which is there in the background. So with that skepticism, I think that we go through it. Sir, do you, if you could just highlight, do you do any kind of, if let us say this patient indeed had atherosclerotic disease, do you have a little bit of trick that you do in your patient in terms of evaluating the common risk factors for premature atherosclerotic disease in Indian patient other than the routine diabetes, cholesterol and whatnot?
Thanks for Anup asking me this. And you will want to know age of menarche, age of menopause, use of hormones for something or the other, and her vegetarianism or non-vegetarianism, and family history of diabetes, B12 levels, homocysteine levels, and many other things. And then all those things matter even today for her. And it's extremely important that somebody who has no obvious risk factors must look for unusual causes and unusual situations. And I would definitely want to know her B12 levels, her homocysteine levels, her history of hormone use, and age of menopause, and hysterectomy or ovariectomy, whatever anything was done, etc. They do matter.
So, sir, if I read your mind, I'm just going to speak aloud these things, and you can correct me or add things as you please. So, early menopause, we are looking at that if a lady has early menopause, then the risk of atherosclerotic development increases. So, if let's say a lady undergoes oophorectomy at the age of 40, then she has got about 12-14 years of risk on her as compared to somebody who attained menopause at the age of 50, which doesn't have as much of risk factor. And the same thing is for the hormonal replacement. If you take longer hormone replacement therapy, then it has been associated with increased risk of coronary artery disease. The role of homocysteine, I'm guessing that if the homocysteine level is higher, then your idea is to replace it with B12 and also screen the family to see if there is any familial hyperhomocysteinemia. And the same thing is with B12 level, that if it is low, that you can replace it. Am I reading it correctly, sir? If there is something that I'm missing, please fill in.
I agree with you. That's what I do.
Okay. Thank you, sir. Anybody has any other thoughts? Santosh, you have your hand raised. Anything you want to add or comment or question? Dr. Santosh, please unmute yourself. Yeah.
What is the cutoff level of homocysteine from which we start thinking in terms of hyperhomocysteinemia and start screening the family members?
Okay, that's a very good question. If somebody can answer that, I will tell you my answer. Most of the labs, they give a cutoff about 15 or 16. So anything more than that would be constituting abnormal. At what level we start family screening, that I don't know. I typically do it if it is more than 20 or so. But I invite other attendees here to share their thoughts on this. Praneet, do you have any number that you chase? Dr. Bharat, if anything that you chase? Anybody? Dr. Chandramukhi?
See, generally, as you said, the level value they mentioned is around 15, and up to 30, generally we don't do anything. Between 30 to up to 100, generally they say that it's a high risk, but if it is more than 100, definitely it needs to be treated. But if you remember all the trials which have been done to reduce the homocysteine, they have not been able to reduce any of the outcomes. So in coronary artery disease, whether it really helps us in assessing homocysteine in terms of treatment it is still doubtful. But in neurological cases, if you are having a high homocysteine and then you start treating, then definitely you are reducing the incidence of stroke in those patients. But in coronary artery disease patient, whether it is a primary or secondary prevention, the data is still very controversial and we still don't know whether we should be treating them or changing them in that aspect.
Perfect, sir. Thank you for that very precise and up to the point answer to that question. Santosh, does that answer your question or you have something else on it?
No, sir.
Okay, perfect. Thank you. Praneet, your take on this and the homocysteine, B12 and any other thing that we discussed?
Nothing in particular, Anup.
Perfect. Thank you so much. Anybody else has got any other thoughts about this particular case?
Anup, I just wanted to also add so-called asymptomatic status or symptoms, interpretation of symptoms in a post-bypass surgery. One must be aware that after bypass surgery, suppose somebody had angina pectoris of a kind, which was diagnostic of coronary artery disease prior to surgery. After bypass surgery, the angina will not be the same in a lot of patients after bypass surgery because by bypass surgery we are denervating a lot of areas. So their symptoms will be atypical. You should be aware of it.
Absolutely, sir. I think that point needs to be re-emphasized again and again, that the symptom evaluation and reliance on the symptoms post-bypass surgery, that is very, very difficult. And sometimes we just have to take indirect cues and proceed further. I also want to highlight this B12 homocysteine thought process. And I got most of my training in the Western world where we didn't talk about B12 deficiency because it's a primarily meat-eating world, and their diet does not lead to that much of B12 deficiency. So most of the discussion that happens and the research that happens in that world, unfortunately, does not apply to Indian subcontext. Having said that, we don't have good data for ourselves either. And I think this is one field where India can certainly contribute to the world, because we do have a very selective subset of population which is not commonly found in rest of the world where active research happens. I must say, not all the part of the world, but most of those part of the world where active research happens, they don't have that patient subset. So this is certainly an area for us to explore in terms of what is the interplay of vitamin deficiency, particularly the B complex one, and how it affects our particular level. It's good to hear that slight derangement in homocysteine level we don't worry too much about, and when it is more than 100 then we certainly should be addressing it. I also want to highlight the role of exercise that these patients should need, because many of the times the symptoms are more exposed when they exercise, and also exercise will act as a trigger for recruiting collaterals. So many of these patients, even if they do have an event later on, the morbidity associated with that event is much lesser if the patients are active versus a sedentary patient. So that is one more thing that I wanted to highlight for all of these cases, particularly females in India who are typically not as, I wouldn't say physically active, but they don't have a dedicated time where they do exercise or whatnot. And that is also something that needs to be addressed in these kind of patients. Any other questions, comments from any person?
No, I just wanted to add, in the interest of everything, that whoever thinks of treadmill or exercise ECG after an entry wall MI follow-up, one must be aware that after an entry wall MI, treadmill test electrocardiogram is unreliable because they have ST elevations with exercise, and that conceals ischemia. So treadmill test is not reliable after a significant antival MI in any patient, whether post-bypass surgery or otherwise. Thank you.
Thank you, sir. Yeah, I started my own system where if a patient had a previous event, I typically don't do TMT in isolation. I always combine it with an imaging. That is my way of doing it. And I particularly think because these patients are at high enough risk that I should image them to look for evidence of ischemia. I do combine it with exercise as a stressor as compared to pharmacology as a stressor, because I want to be as physiological as possible. It also gives us exercise tolerance and whatnot. But when they cannot exercise, then adenosine becomes my drug to go. Santosh, you have anything to add?
This is out of context question. Since she's in 53, 54-year old, she will be, if suppose she is menopause and she has postmenopausal symptoms, will giving hormone replacement therapy is a good choice to her if gynecologist advises?
So, okay, I think this is, so hormone replacement therapy is more or less outdated these days, and many of the time if you have a perimenopausal woman who do have symptom, gynecologist will not write HRT unless they get a so-called cardiac clearance. And at least in this group, I wouldn't be giving the clearance to her. I don't know about other people, what they would do. But I think giving a hormone replacement at this time, particularly estrogen-based hormonal replacement, is too much to ask for. That is my thought process. Progesterone I'm still okay with, but estrogen certainly not. Anybody else has got any thought? Maybe Dr. Chandramukhi, you can. You have been silent for a long time. If you could guide us about whether you will clear this patient for hormonal replacement.
No, I will not clear this patient for hormonal replacement because already she is having coronary artery disease, and I will not give any clearance for the hormonal therapy.
Any other person with thought process regarding this particular question, whether she should get a HRT here on or not? I personally wouldn't do it. Okay, so that question, no takers. Anybody else has got any other thoughts, questions, comments before we start winding up today's session? So this is the case that I brought today is a very routine, very simple, but it brings out a lot of discussion point, particularly what Dr. Somaraju was saying, that we need to dig back 5-6 years ago and start questioning the whole background of why this was done to begin with, because certainly diagnosing whether she had atherosclerotic disease versus not will give us some idea about how to proceed in her versus her family members. And once we have a lead, then we can start tracking. Like, let's say if you figure out that this patient had some sort of connective tissue disease which led to early coronary disease, then now the whole rationale of family screening changes. So that is what I would see. Dr. Vrinda, your hand is up. Do you want to add anything or have a question about this case?
Hi everyone, sorry I just caught up late, but on the question of HRT, I just wanted to add that I think after the initial, the big study, the Women's Health Initiative showed that, there's an increased risk of cancer and coronary artery disease. I think there have been multiple papers, analyses done, and what has been shown is that if you start HRT soon after menopause, up to a period of 5 years, it's been deemed to be okay. So for the right kind of person, if they are very symptomatic, HRT can be given if started early after menopause for up to 5 years.
Perfect. Thank you so much for that, Vrinda.
And I also want to agree with Dr. Vinda. The women's heart study is not particularly reliable in certain issues. Many of these patients, when they were part of the study, they also took care of a lot of many other things. So we cannot, they are uninterpretable beyond a point. I agree with her.
Thank you so much, sir. Anybody has got any other thoughts, questions, or comments? If not, then I will ask Praneeth to give his closing comments about today's session, about the topic and how we did for the discussion.
Yeah, Anup. So as you said, routine run-of-the-mill case which we see in day-to-day practice, the point of trying to highlighting about primary prevention of ASCVD in family members, particularly for someone who comes like this, because this is something which is easily missed in routine practice, where the attention is every time on titrating the medication or giving focus only on the patient, and it equally gives us an opportunity to the so-called primary prevention in the family members. So that point is valid, has to be kept into mind. And regarding the patient per se, the point of trying to look back, what was the indication, what are the risk factors, and what can we know about this thing. Again, digging in the past is worth an attempt, trying to know better about the patient. And as everyone suggested, making the patient medicines better, be it moderate to high intensity statin, making the targets reaching, be it heart rates, blood pressures, and the lipid therapy, and a stress test to know the anatomy better, or the myocardial perfusion or the reserve better, and risk stratifying the patient. So these are the take-home point from the discussion, and many value-added points which were there in this discussion. So a good discussion, I would say.
Thank you, Praneeth, and thank you all the attendees for today's session. To the attendees, particularly those joining us for the first time, we would like to get your feedback. If you found the session worthwhile, may we request you to share it with your colleagues so that more people can participate and engage in thought sharing. We do this session every day at 7:30 and we record these sessions. These sessions are uploaded on podcast and YouTube. And I typically am a bit slow in uploading them, but eventually they will come up. We have about 20-25 previous episodes uploaded. You can just go to podcast or YouTube, search for the Weekly Huddle, and you should get one. And again,
Anup, can I interrupt you?
Yes, sir.
Can you make it 7 p.m. and please ask others what they think about starting at 7 p.m.
I will ask the attendees to see if we can change it to 7 p.m. This message has been, the 7:30 timing has been shared across close to 500 people. So I will get their input, and if we think that 7 is a good time to start, I will certainly look into that. And again, I thank you all for participating, and we will meet next Wednesday. I wish you all a good night and see you again next time. Thank you all for participating.